This is Dr. Janice Makela. I'm a doctor with over 20 years' experience in geriatric medicine, hospice, and also a great deal of experience in cannabis medicine. I am once again here to answer your questions that you may have on various different topics. Welcome to Questions and Answers with Dr. Makela. The Yes. So, thanks everyone for joining us. And here, turn that sound off. Perfect. So we're just streaming here, making sure that the stream's going through. We were having issues last week, and now it seems like it's actually working. So that's good. I've spent some time. You may have seen some videos pop up this week of me troubleshooting the live stream. Um, but it's up and going. I hope everyone's having a great day and everyone's had a great 4th of July weekend. Show off. I have my little fingernails done up still for the 4th of July. But anyway, I hope everyone's doing well. So today I wanted to talk a little bit about a geriatric topic. We'll start off with this, and then, of course, we'll see how things lead us. One of the things that we run into sometimes in the geriatrics is what's called elder abuse. This is when people are older, right? And they're more dependent. And what ends up happening is a lot of people with elder, um, as they become dependent, they're very much more prone to being abused. Now, it's interesting because we talk about child abuse, and that's very terrible, very awful thing. And then on the other spectrum, we have elder abuse. But elder abuse is a little bit different because elders are considered um, to be able to make their own decisions. So, one thing we have to look at sometimes in elder abuse is this person decisional? Are they able to get help? So, in the state of Illinois where I live, I'm a mandated reporter only if the person can't ask for help. Um, if they're bedbound and they can't get to a phone, if their abuser can keep things out of their reach so they can't get help, if they are cognitively impaired, is the most common situation you see where someone doesn't even know how to use a phone, not even quite aware of what's going on. Now, they can be aware of pain, they can be aware of neglect, and they can still suffer a great deal. And so people with Alzheimer's or dementia, they can still feel being abused. They can still feel the insults and the neglect and the pain and the bed sores and hunger if they're not being fed. You know, this is why it's such a big issue with elder abuse, especially in people with dementia. Now, what we kind of get into a little bit of a gray area, and the reason why we kind of have these things is people have the right to be in domestic situations that are abusive. And we can't make someone who's cognizant and aware of their situation leave um, a domestic partnership that's abusive. And just because someone turns 65, that doesn't change unless that person is now not able to care for themselves or now has some cognitive memory issues. Now, suddenly, that domestic violence grown old, as they call it, is now elder abuse. And then we have to really address that. Now, yes, do you address domestic violence? Yes, yes, yes. As medical practitioners, as providers, when we see domestic violence, we want to help people and help them get the resources they have. But at the end of the day, the person has the right to say no. And and we can't just go swoop in and arrest the person unless, well, there's some different things, right? unless there's a crime that's been committed or whatnot. We can't arrest the abuser in a domestic violence situation. And it gets weird, right? In a older situation, though, there's a little bit more. It changes again. If that person can't make up their own decisions, if they're dependent, now it's elder abuse. And what's also very interesting is elder abuse is actually a lot of different things. You can think of physical abuse, actually hitting someone. I've in my career seen a few. I saw one poor lady with dementia who had burn marks on her from a heated wire coat hanger. Uh, hmm, and ligature marks on her wrist from being tied down. I've seen a few nasty things like that. So yes, it can be physical. It can be neglect. It can be where someone is not cared for. They're dependent. They need 24-hour care. They need assistance. They need help. And so you see situations where someone may have a uh, um, be neglected, where they have bed sores and infections, and they're not getting fed well, and that can be neglect because they can't feed themselves. They need someone else to feed them, or they can't go to the grocery store and no one's bringing them food. And this is particularly when there's someone whose job it is to do that. Now, what's interesting is about that is that there are people who neglect can be benign or it can be very bad, negligent neglect. So, benign neglect's your 90-year-old spouse. They already have a little dementia themselves. They're caring for their 90-year-old, patient, right? Who is bedbound and they've been doing stuff, but now they have gotten a little bit of dementia or they're not really able to handle everything. And they feel like it's their job because they're the spouse and that's their job. And I have to do this. And no, I don't want the kids to help me. I can do this. That's benign neglect. That's someone who's really trying to do their best but is overwhelmed. You might also see that with a child who's managing children of their own, a job, and an adult family member. You can have good intentioned people commit neglect. And so this is as opposed to someone who's taking the money, using it on a lot of different things that they shouldn't be, and not spending the time that they should to care for someone, or maybe they're taking their social security. Now that actually then overlaps a little bit with financial neglect, where people are stealing from someone and saying, "Oh, well, gee, they're not using it. How much more do they have left, in their life? I'm going to take this money." And it's particularly bad when that person now doesn't have money to care for themselves. I knew of a case where a lady had given a patient, a family member, a distant family member who was her sole caregiver, money to pay bills, and they would waste it on alcohol or something else, and just pay the bare minimum and not provide for her. So the when she was finally found by someone who was able to get her to a hospital, she was laying in a bed sores, emaciated, cockroaches on her, with I want to say a melted candy bar, if I remember right. That was the story I was told about this lady, and thankfully, someone else in the family stepped up and was able to provide for her. But that's the type of abuse um, that you can see with neglect. That's the difference between benign neglect and actually it's sort of aggravated neglect. Now, then there's emotional neglect where someone's calling people names and or sort of doing sort of emotional ugh, stuff on them where they're saying things like, "You're a bad parent, you're a bad person." You know, on a range between emotional and physical. I've actually had a patient who was the cops were called because the neighbors saw that they were being locked out of the house. They were sitting on the back porch and were banging on the door and unable to get in the middle of winter because and the caregivers, the family who was caring for them was like, "Oh, well, they peed on the couch again." It's like, mm, mm. And so the punishment for peeing on the couch was they were being locked out of the house in the middle of winter. Again, physical, but also kind of this emotional thing, this sort of treating someone like they're a bad child who deserves all this punishment. And of course, children don't deserve that punishment either, right? But you know, I mean, you're sort of infantilizing the person. And so that was a really sad thing. So emotional neglect, where you're are being very mean to a person, or the words you use are extremely hurtful, and maybe you even do some sort of psychological abuse on them. And then there's sort of also, you can keep a person isolated. That can be sort of an abuse. If that person wants to go out and do stuff and they can safely do that, but maybe they're in a wheelchair or they're bed bound. And with some help, they could do it, but you're like, no, 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 no. That can be a sort of an abuse. Again, part of that physical, emotional abuse. And then, and then I apologize. This is a little bit not safe for work if anyone's at work, just a little caution, a little trigger warning, so to speak. There is sexual abuse of elders. It does happen. We don't even have a word in English for it. That's how much we don't want to think about that. I mean, when we think about it in every other context, there's some sort of word or something. But sexual abuse of elders, we don't have a word for that. We don't want to think about that, but it does happen. I've seen some cases in my years of people out of nursing homes where someone's come in and you know it's it sounds weird, right? But it's because that person is sort of the ultimate victim, right? They're bedbound. They can't fight. They can't scream. They can't, you know, and right? But it does happen. So and it's important we talk about that to know that that is a thing because sometimes in medicine we miss it. People will sometimes women will get very protective of their abdomen, around their lower area if, when suddenly the nurses are trying to clean them and they're like, they weren't like this before. You'll suddenly get behavioral changes that you didn't have before. And you're like, what's going on? So, yeah, it can happen. Now, so those are the types of elder abuse. And so that was a kind of just some things to be aware of as people get older that this happens. Risk factors can include dependence, caregivers, if the caregiver is financially dependent on the person that they're caring for example, the caregiver lives with them and the person who is they're caring for is getting a social security check or a veterans check or some sort of check in the mail regularly and that caregiver is living off of that, that's actually a risk factor. If the caregiver is using substances and if the patient is isolated and again dependent, these are all sort of risk factors that, again, I mentioned about spousal abuse growing old, that can be a risk factor. So if you've already been abused in a in your relationship, that's not going to stop necessarily as you get older. As a doctor, I'm a mandatory reporter. If a person can't call, get help for themselves, I have to call. Now, the good news is a lot of these state organizations, when they come in and investigate, they don't just go in and go swooping in and say, "Oh, we're going to take everyone away. We're going to put the loved one in a nursing home. We're going to lock up the abuser." They're going to look at the situation and they're going to do their best to try to make a fair assessment. They're going to try to tell the difference between a 90-year-old who's caring for their spouse and someone who's not doing a very good job and is being very abusive. They're not going to necessarily lock up everyone and put, they're going to, if that 90-year-old needs resources, they're going to give him the resources he needs. Or they're going to send in a social worker to have some conversations. If the person's in imminent danger, if that 90-year-old themselves is bedbound, then they're going to bring in other family members, do some other things. But otherwise, there's going to be a lot of support. If that caregiver, that daughter or son who has the kids and the parents and the everything else they're looking for, again, get some resources, maybe get some homemakers, get some other people to help, maybe talk about placement. Say, listen, you can't handle this. Let's talk about placement. So it's not going to be this huge punitive thing unless it needs to be, unless that person who's taking care of them is really abusing them. Then, yeah, it's going to be, and that's okay. Now, that's kind of some of the abuse things. Is cannabis abuse? And by that, let's say you got an elderly patient who has dementia and you give them cannabis to help with their behavior. Well, that's one thing you got to be a little bit careful about. You know, if you get someone who's really, really, judgmental about that, you could make the case it's not federally legal. You're giving them an illicit substance and you're not telling them. So I would make sure that you have, if you're going to do cannabis in a geriatric patient with dementia, that you talk to the doctor, that you let them know that this is a plan, that you make it part of the treatment plan. Because if you just start starting to do that by itself, you might find yourself in a little bit of trouble if someone takes it the wrong way. If you got a family member who suddenly goes, "Oh, you give them cannabis?" You want to be very careful with that and make that a plan. So that's just the one caution about that because and then the other question is you want to make sure why are you doing it? Are you doing it just to help the behaviors, to help them sleep at night so they don't scream out, so they feel a little bit more calm, or are you completely snowing them? There is sort of a medical restraints where you're giving someone a medicine to make them sleep all day. It's not necessarily good, right? So you want to, again, and then even if that's not what you've intended, if you got that family member or someone who's freaking about it, that's how they're going to portray it. They're going to say, you just want them to sleep all day, and that's why you're giving them the cannabis. And so you want to make sure that this is a well discussed plan. It's not just, let's try some gummies and give it to them. You want to talk with your doctor. You want to make sure that it's the right dose, that it's the lowest dose. And you want to talk about even with family, right? Say, hey, yeah, we're going to try this and see how it works. And so that's my thing about cannabis. The other thing I would say is caregivers. I just always ask, and I see we have someone who's talking about talking, and actually, this segues nicely into the first question we have here. Trisha Brown actually put a nice little comment. Here, let me just highlight it. She said, "Thank you for what you're contributing to in the cannabis space. I recently took an end of life coaching program. I plan to help clients and caregivers integrate it into the wellness regimen." And I think that's a great idea. Again, open conversations, let people know about it. But one thing I would say, I have done many home visits in hospice over the course of my career. And if there's one thing I could ask caregivers, a lot of times it's the caregivers doing it, but sometimes it's the patients and patients. Please don't smoke your cannabis right before you know you're having an appointment. There have been times I've gone in and the house is like, whoa, I'm glad this is my last appointment for the day because the next people would be smelling it on me. And so I I have to you have to be careful because that's an occupational hazard for me and nurses and home nurses is if someone's smoking their cannabis and then you come in and do a visit. Um, in fact, one thing I would suggest if you're doing it medically and they insist on smoking it and you're like, well, it's end of life and they're not using oxygen. It's not going to hurt anyone. Is encourage them to get a box that, takes the smoke and filters it so it doesn't go into the room. So that especially and to be running it right before you come to visit, right? So that would be some of the recommendations I would say about that is that be aware that when we do that, that's a risk to us home care people. I actually had a patient whose I had was concerned about their care and had the Department of Aging involved. And in that case, the one of the visitors, the home nurse that I think the Department of Aging was sending to check on him, couldn't even get into the house because once they did, there was so much smoke from cannabis, it wasn't safe for her. You know. So in that case, she didn't even do visits on those days. And so mm, that is one of the things that I caution people about. Now, other things about end of life coaching programs. Personally, I want to see a day when cannabis is right along morphine, Ativan, and Haldol as the core medications for what's called a comfort pack. In hospice, we give patients a thing called a comfort pack. And a comfort pack is a medicine, a pack of a bunch of different meds, one to, and it's Haldol for when they get end of life delirium. And yeah, I know you're like, oh my gosh, Haldol. A lot of people, if they know Haldol, are probably freaking when I say that because Haldol is an extremely strong antipsychotic and it snows people, makes them tired, and has a lot of side effects. It's not a great drug, but at the end of life, when a person is going through what's called terminal agitation, that's in the last few days of life, they start getting this sort of, some people can get very agitated. They can get very um, anxious. They can not just anxious, but they start hallucinating. They start getting out of bed. They start seeing stuff. Now, yes, we get some of that stereotypical stuff at the end of the life. The reaching for the light happens all the time. We see that. We see some people talking to dead relatives, and that's not necessarily a bad thing. That's actually a sign a person's near the end. I'm talking about where they have no idea what's going on, and the toxins are starting to build up in the brain as the body is starting to shut down. And now they're not just reaching for the light or talking to dead relatives, they are just completely out of it. And maybe they might scream, yell, or say words that make no sense over and over and over and over again. They're not resting, and the caregiver isn't resting. Haldol can help bring that down. Ativan, if a person's very anxious, if you think it's a little bit more anxiety driven, again, sometimes it's the toxins building up, but the anxiety, Ativan can help. Morphine, of course, pain, but also shortness of breath. It turns out that morphine is chemically related to cough syrup, so that when someone gets very short of breath, at the end, you get this very rapid breathing. And I can give some morphine to calm that breathing down so it's a little bit slower and a little bit more comfortable. Or if someone is having trouble breathing because they have a respiratory or cardiac problem and they're, I can't breathe, morphine actually calms down the chest muscles so that a person can breathe comfortably. So that's how morphine can help. Now, and then of course, pain. I want I want cannabis to be available. I want a nice little concentrate to be able to put under someone's tongue at the end of life. I think that would be great. Not only for nausea, yes, we have compazine in we have a variety of different medicines. Ativan can help with it. Haldol can help with it with nausea. Compazine can help. Sometimes people get nauseated because they're constipated, so we have laxatives. All of those are in a comfort pack. But the morphine or but cannabis And, yes, it helps pain, but it works at a different point of pain than morphine. Morphine works at one point, cannabis works at another. And so they can work together. And so sometimes people can take a little bit more cannabis and a little bit less morphine and find a nice balance that helps them. And then the other thing is that cannabis works on the emotional area of the brain a little bit more. So sometimes people, if you say on a scale of 1 to 10, how bad's the pain, it still might be 7, but they care less about it. It's impacting them less. Whereas morphine might actually bring that 7 down to 4, and they still might be very anxious and worried about the pain. I think that synergizes nicely. So I think cannabis can have that role. And me, I would like to see it part of the the hospice world. Unfortunately, because Medicare pays for hospice, no one does that. We can't. We'd get in trouble. Um, so personally, that's where I say reach out to your senator, call out to people, say, hey, at the very least, dying people should have cancer. Not cancer. At the very least, dying people should have cannabis. How is it that we can't get that for people who are dying? That's crazy, not to mention people who actually need it. So that's my spiel on that, a personal issue. So thank you, Tricia, for touching on that. And I'm so glad to see that you are working on that, to help people try to integrate and teach them how they can use it. Because as a hospice doctor, I can kind of teach them, but I'm sort of looking a little bit on the side here. I can't write it in my notes. I can't say, I told the patient to do this. Um, I have to say, yeah, they're taking it, and then off the record, maybe help them a little bit. Hmm. Hey, Lance, nice to see you. I hope things are going well for you. So, hope you had a good holiday. So, yeah, it's been it has been a interesting thing. Now, if you got other people again, oh, hang on, let me try this. It didn't pop up. There we go. Oh, it disappeared after I educate, educate, educate. Right? That is the number one thing that people have that they need. I've been looking into the whole industry. I was like, maybe I start my own brand. I didn't. It's too saturated. What I found was that the number one thing that's needed is education. Patients don't know cannabis or medicine. Doctors don't know cannabis. Medicine doesn't know cannabis. Cannabis doesn't know medicine. You know, and and so all of these things, right? The cannabis doesn't know medicine, and patients don't know either. So the more education there is, the more resources there are. And that's why I'm doing what I'm doing here. I'm like, I want people to know more about the medical aspects of cannabis. You know, and it drives me crazy sometimes that it's still considered Schedule 1. I will say it, and I've said it many times before. I can prescribe cocaine. I can prescribe cocaine, and I cannot prescribe cannabis. I can prescribe meth, and I cannot prescribe cannabis. I have prescribed more opioids than anyone else in the state one year. I was working in the post COVID in a hospice that was understaffed because COVID, and had was working in the large metro Chicago area doing hospice. And I got a letter from the state saying, Dr. Makela, we'd like you to know that you are in the top 5% of opioid prescribers. And I'm like, yeah, I better be. I have a whole bunch of hospice patients, and I prescribed a lot of opioids over that year. And, I didn't have to do anything about it. They just wanted me to know that they knew. But that's that is that's the crazy world we live in. And hey, if anyone has a fast track to talk to anyone in the who can make a change, let me know. I would love to spend a little time and educate them about the endocannabinoid system. Um, Personally, I think that if I just had 10 minutes with Secretary Kennedy, I could talk to him and educate him about the endocannabinoid system, show it how it works great with MAHA. I mean, we've talked before about omega 3s and omega 6s and how that is tied to chronic disease, that balance, and that's all endocannabinoids. And then explain that, yeah, then there's some people who have too much of it in their system, and then there's some people who have too little. And that's why we need cannabis for those people who don't have enough. And then for people at the end of life, again, why can't people at the end of life get cannabis? So, oh, Sean, thank you. Let me get this up here just so people can see it. A great filter for patients. Okay, awesome. The hot box. I think I saw that at Benzinga's. I could be mistaken. I think that's what you. I don't know if that's your product or if that's just one you've used before, but I think I saw someone demonstrating that at Benzinga. But that is a but that is great because yeah, if you smoke, if we have patients who are smoking and we're doing home visits, we really should encourage them to get some sort of filter so that we can safely visit them. Mm. So awesome. The but yeah. Now speaking of politics, there is some stuff going on. Apparently, the big beautiful bill does not have anything about cannabis in it, but there is talk. There's a different bill. Americans for Safe Access just had a whole thing on it last night about how there's a different bill. And normally, what happens is that they put in this appropriations bill or something like that uh, terminology and renew it every year to say that the government cannot go after people in states that have legal cannabis. They can't, raid dispensaries. They can't go in and attack people who are using it medically or whatnot and, arrest them for medical cannabis. That was, and that the feds were not going to be given money to do that. That terminology is not in the new renewal of that. And that's a little bit concerning because without that, now there's a question, could the state um, come in? That's where the state could come in and seize things. So that is very, very concerning. And so you definitely, especially if you are in a state that has um, Republican legislatures, if you have a Congress, if your Congress people are Republican, where they're going to have a lot more say in this current situation, eh, reach out to them. Let them know. Let them know, hey, we want to make sure that cannabis patients can get it safely without the feds raiding their house and saying, oh my gosh, you have too much cannabis. How dare you have this RSO? An RSO would probably be over much of the legal limits of what cannabis would be considered legal. So Sean, you saw it over at Benzinga too. Yeah. No, Benzinga was really cool. I liked that. That was very interesting. We had some uh, I had s- I met a lot of really neat people there and saw a lot of cool things. The you know um actually speaking of Benzinga, one of the things they have is the what is it? No prisoner left behind or no Last Prisoner uh, people. And I want to say there's a couple other organizations out there too. Last Prisoner Project, I think, is one of them. And it's this idea that there are people still in jail for cannabis. And the only thing they did was cannabis. You get a little bit of gray when you get someone who's pulled out a gun, robbed someone, and then also was doing cannabis. Yeah, okay, that's different. But if someone's only crime was they were carrying cannabis or selling it, then what? You know, and I guess that's one of the things we have to kind of spread out is how do we tell people? How do we share with the people who make decisions to say, hey, this isn't what you think it is. This isn't all just a bunch of people who are criminals. This is people trying to take care of themselves. This is people who need it medically. And so that is one of the things I want people to do is just reach out to your congressman, reach out to your you know, legislature, reach out to anyone in politics and let them know how important this is to you. Because if we stay quiet, they're not going to hear us, obviously, right? So I would say let's make sure that that's my call to action is to say reach out to people, let them know how it's made a difference in your life. If you have people who it's affected medically. Okay. Trish, hey, thank you. Thank you for watching. You know, I know it's the middle of the afternoon, so for some people that means you got to work, right? But I really appreciate you coming in. And thank you so much for the good questions and the comments. Mm. So, let's see. An interesting thing that I had read about recently, um, sleep apnea. Now, this leads to an interesting question. I'm saying interesting a lot, I've noticed. But a lot of this is interesting, right? So, anyway, sleep apnea. So, there are a number of studies. There's some meta analysis even that look at it that have looked at dronabinol. Now, dronabinol is medical, um, FDA approved cannabis. It is synthetically made. It was made back about 20 years ago for appetite stimulation in HIV and nausea and chemotherapy. Those were its two evidence thing. And it was kind of a pharmacy answer to say, hey, okay, cannabis is illegal, but we're going to synthetically make something that is cannabis. But because it's synthetically made and not grown, it will be legal, it'll be FDA approved. And and so they've done this. That's dronabinol. Now, I remember when it first came out and we were trying to use it a little bit for dementia, people who weren't eating. Eh, it got mixed results. I was never a huge fan of dronabinol. That and it was $600 a month when it first came out. And so it was really expensive and so the drug companies, made a lot of money off of it. But it's like, why would you spend $600 a month on this? And a lot of my Jerry patients didn't do great. And, one caution I will say sometimes in older patients is if they don't know they're going to get high, you give them a huge dose. Like standard dose of dronabinol is 10, though you can cut it in half to 5. Whereas with cannabis, I would say you'd want to start at 2.5 or 1.25 for a very elderly patient. Now, dronabinol was given at a little bit of a higher dose. Now, what's happened is there's been some studies to show that it helps with sleep apnea, which blows my mind. Because when I read that, It didn't make sense. We always hear cannabis, "Oh, it makes you sleepy, makes people sleep well, knocks you out, makes you tired, makes you loopy." All the things that normally would be bad for sleep apnea. You'd be like, yeah, you're not supposed to drink alcohol if you have sleep apnea. You're not supposed to drink any sedatives or take anything because that makes it worse. Because what happens in sleep apnea is that your throat muscles get kind of limp and they sort of they get when you sleep, they relax and then they don't keep your throat open. And it's worse if you're overweight and you have fat around your neck and stuff because then that pressure can kind of build up too. At least that's a theory. Though now I'm actually wondering if maybe the endocannabinoid system is doing it and maybe it's association as opposed to causation that the same thing, the same dysfunction, the endocannabinoid system that's making people be overweight, such as, having too much processed food with omega 6s or something like that, might be playing on that a little bit because this is what happens. Dronabinol actually stimulates the vagus nerve in such a way as to keep tone in these muscles when you sleep. So instead of becoming flaccid and relaxing and closing up so that when you try to breathe at night, it's all closed up. And so you can't get good air. And so thus you snore. And then sometimes you don't breathe. And then when you don't breathe, you wake up and then you go back to sleep and then you're not breathing and you wake up. And so you're not getting a good night's sleep. Or you sleep, but you're not oxygenating very well. And so your oxygen will go down low. All of that can be bad with sleep apnea. In fact, sleep apnea isn't just snoring, it can lead to heart failure because the right side of the heart pumps to the lungs. And if the right side of the heart is pumping to the lungs and there's no oxygen in the lungs because you're not breathing, then that low oxygen triggers the blood vessels to kind of close off and say, there's no oxygen here. Don't send the blood this way. And so all of the little blood vessels that are there to try to get blood oxygenated into the lungs, if you have, it's like a traffic jam, right? If you close this area for construction, close this area, and close this area, and close this area, if you close a bunch of spots for construction, now you have increased traffic in an area, right? It's the same way with that lung. If you say there's no oxygen here, no oxygen here, no oxygen here, and the blood closes off because it says, why even bother? There's no oxygen there. We're just going to go where the oxygen is. The blood vessels now have increased pressure. And so that increased pressure creates stress on the right side of the heart. The right side of the heart just normally has one organ it pumps to, the lungs. But now, if the pressure in the lungs is higher because so many of the ways it could normally take up and closed off, and again, think of an expressway with lanes closed off, right? Same idea. Now, suddenly, there's so many cars trying to get through. That's the same thing. Now, there's so much blood trying to get through a more narrower area and that creates pressure and that creates work on the heart and you can actually cause failure. There's so much stress on the right side of the heart that you can get heart failure after many years of having untreated sleep apnea. So it is a serious condition and there's been several studies to show that dronabinol can help with it. And again, mind blown on that. But the Society of Sleep Specialists has come out and said, no, don't use cannabis. There's no evidence that long term use is helpful. No, don't use dronabinol even because it's still not FDA approved. All of these studies have only been up to level 2. Now, I told you that 20 years ago it came out when I was first using it in geriatric patients. When I was first starting out as a doctor, it came out. And that is interesting because that's about the length of a patent of a medicine. Dronabinol, I believe, is now not patented. And just this last month, there came out a study where it was dronabinol combined with another medicine. I want to say acetazolamide, which has some evidence that it can help central sleep apnea, which is a different type of sleep apnea as opposed to obstructive. This is obstructive, where the throat kind of closes off. Um, a central sleep apnea is where things kind of from your brain y- you stop breathing. There can be different things. It can be a medication effect, it can be a disease effect from different things. So, acetazolamide has some evidence that might help central sleep apnea. So, they did a combo pill and they did a test and showed, yeah, oh, yeah, look, it helped. So, I personally think that what's happening is you're going to get a combo pill that the company's trying to get FDA approved because the original pill is no longer under patent. So they can patent their combo pill and then get that approved and then make a lot of money and charge a lot of money for it. Now, again, the sleep specialists have come out and said, no, 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 don't do it yet. No, data's not there. And I will say this, if you have a sleep apnea and you are using your machine, please don't stop using it. Keep using it. That is the best treatment we have right now. Uh, the data is really promising for sleep apnea, for cannabis use, for dronabinol, but it is not 100%. It's not necessarily, slam dunk. Yes, it's helping. And we don't know. The sleep specialists aren't wrong. We don't These studies have all been up to so many weeks. We don't know if you do it every day for the rest of your life what type of side effects are going to develop. We don't know if it's better than the machine. Now, if someone can't take it, refuses to take it, first of all, the machines have improved over the years. If you were told you have sleep apnea and you tried the machine and it didn't work and you were feeling bad about it, you were feeling bad when you were taking it, you might want to talk to your doctor and maybe even talk to a pulmonologist or a sleep specialist because there are now for mild sleep apnea, there's actually devices that you can use to kind of keep the mouth open. There are different surgeries they can do now. And there's even different ways, like you can do it through the nose, or there's different ways they can do the sleep apnea device to make people more comfortable. So I would definitely pursue that first. 100%. I have to agree with them on that. But keep this in your thoughts. And if after doing all that, you are not able to take it, not able to handle it, talk to your doctor. Bring these papers, bring them, and say, hey, I heard that cannabis can help sleep apnea and papers on it. A little Google search, you can find them. And what do you think? Should I try it? Should I, and maybe. Uh, I have some ideas. Definitely, Sean. I would love to talk to you further. Let's see. Oh, yeah. Here you go. Thanks for the session. I have to go. Let's talk. I have some ideas for applying our drugs in clinical trial status. Ooh, you keep me posted. I'd love to hear more about it. So that's awesome. So, yeah, that was some of the news with sleep apnea. That was just kind of a new article that came out recently and it kind of blew my mind a little bit. But again, if you have sleep apnea, don't throw away your machine and use cannabis. There's no evidence that cannabis works better than the machine. It only works better than placebo. So, if you absolutely can't use it and you are just saying, I'm just going to deal with it, well, first of all, lose weight, right? And work on that. Eat a healthier diet, eat as we all need to do, right? um, and then and then talk to your doctor. Maybe that's something to consider because maybe it's better than nothing. But again, now there is an interesting term, and I'm just going to wrap things up kind of with this idea. And of course, if anyone has questions, chime in, right? Um, there is an interest, there is a term in medical literature when we have something that we do not have the answer for. So the research, the guidelines, for example, prostate cancer screening is a classic one. Prostate cancer screening, prostate cancer is extremely common cancer in older men, but you can screen for it with a thing called the PSA test. And you do the blood test, and if it's high above a certain level, then we go and we send them for further study. You can check the prostate. Is there a bump? Is there something? Send them to urologists. They can do an ultrasound, look to see if there's anything that's a mass. And then if there's a mass, they can biopsy it and determine if there's cancer. If there's cancer, they can take it out. And the whole idea of that was it would save lives. But what they found out was there was a lot of people who were getting really invasive treatments, biopsies, surgeries that could cause incontinence and impotence, severe, consequences, right? And they were getting all these things, but at the end of the day, when they did the data, these were wussy prostate cancers. They were prostate cancers that wouldn't have killed you. Plus, the new medicines that have come out for prostate cancer, people can live 10, 15 years. And so there's become this huge debate. Do you screen for prostate cancer? When to screen? Are we hurting people by screening for it? Because you get all these people who would have died with the prostate cancer. They would have died at a heart attack in their 90s and still had the prostate cancer, and it wouldn't have killed them. And how do you tell that from the person who would have died of prostate cancer in their 60s? And so the guidelines now have a cutoff. They say beyond this date, you probably should not be screening for prostate cancer. Because if you're 85, 75, 85, and you get prostate cancer, a lot of the drugs can keep you alive for 5, 10, 15 years. And because of that, you you're gonna die of a heart attack first in your sleep and in your 90s. Conversely, someone in their 60s, they say, yeah, okay, maybe you should. But they use a term now. Uh, they say decision making. It's not joint decision making. That'd be a great term. Joint decision making. When we talk about cannabis, it certainly would be joint decision making, right? um, but it is this idea that you talk with your doctor, you talk about your specific risk factors and your specific values and your family history. Did your brother have prostate cancer? Your dad had it? Is strong in your family? You're going to be more likely to get tested for it. Um, did you have risk factors that make you more? Are you at an age group that you're more likely to have an aggressive cancer as opposed to if you're older, where you might get some of the weaker cancers? So, those sort of things are things you might talk about. And then you make a decision with your doctor about whether or not to get tested or not. And so they use this phraseology a lot in whenever the data is gray. They will make guidelines and say, this should be done after a discussion with your doctor about the risk and benefit and joint decision making between you and your doctor. Why is cannabis not this? Why do we always all come out and say, cannabis, we don't know if it works, so therefore we can't advise it? And it's because it's Schedule 1, I think. I think because it is illegal and because we don't have the research and because it's not patentable, and so thus you can't have your single drug effect because we don't have a lot of research because it has been illegal. A lot of people are scared to say just go off and do it. The other thing is, I think a lot of people, because there has been this disconnect between medicine and cannabis, there's this fear that if we just say, go ahead and use cannabis, everyone's just going to run to the dispensary. You know, in the case of sleep apnea, throw away their devices and start using cannabis. We don't want that. And because they're not doing it in conjunction with their doctor. Of course, the doctors need to learn more about cannabis too. And that's why I'm here. I'm hoping that we can train some more doctors in this, some more healthcare professionals in this. And so that is, you know, so I think there's this kind of hesitation when a phase two trial showed that twice as many people survived with brain cancer and chemo with Stativic, so 1-to-1 THC CBD, and versus people who just had the chemo, that twice as many people survived if they had the cannabis versus not having the cannabis. The BMJ had to put a big letter. It says, "We still don't know. It's only level 2. We don't recommend you telling people to use this." I agree, but I think we don't want to get overhyped. We don't want to say, "Oh my gosh, it can cure everything." But at the same time, when you're dealing with nothing, when you're dealing with no options, when you're dealing at end of life, when you're dealing with someone who has no other treatment options, who has an incurable cancer that is getting chemo in the hopes that maybe it'll help it get better, to say that taking cannabis, I, I don't know, if someone I loved had brain cancer, I'd encourage them to take it. And that's where this risk benefit, that's where looking at cases individual, that's where these individual conversations need to take place. And I wish it happened more. I wish we looked at it that way instead of just so absolute and said, conversely, I have I have seen people who cite data, especially with the cannabinoids where we don't have a lot of data yet. A lot of the cannabinoid data is only animal data. We have the world's healthiest mice. And that's going to be a little bit more down here. If it's just animal data, now we really have to look at that risk benefit. Is it really working? Maybe, maybe not. But what are our options? What else is out there? Where are we now? What are our benefits? What are our risks? You want to look at all those things and then you can make a decision. And that's kind of how I think we need to be approaching cannabis. You know, no hype, but also understanding that sometimes it's not always um, bad, right? Mm. We are at 3:57. I uh, I hope everyone is doing well. I hope everyone has a great weekend. I've learned that there's a little bit of a lag here, so I apologize if people start typing in the last minute. I might be already gone because it seems like I record and then LinkedIn is actually taking about 30 seconds to 30 to 90 seconds to processes it and then display it to everyone. I spent a great deal of time this past week going through some help desk stuff only to find out that it's because LinkedIn has decided to optimize the smoothness of the data in exchange for the speed. Whereas something like Twitch, where you have gamers streaming and you need to do everything in real time, um, you have a latency of about 3 seconds, and YouTube has about a latency of 15 seconds. So if this has been an issue for you when we've been doing this, if you're like, wow, it takes a long time for my comments to load, then feel free to stream from YouTube or Twitch where things might be a little bit more real time. Um, but I don't think you guys would see too much from it. Just to be aware of that. Also, next week I'll keep you posted. But I might not be doing this next week. I have a conflict and nothing serious, but we'll just, I have to actually see the timing of it and see if it's still possible. So I'll keep you posted if we do have something next week. But it looks like next week I will not be doing this. Um, and then after, I'm thinking in August or maybe the last week of June, July, I will be doing a evening podcast too. I will be doing the afternoon because I think there's a lot of people who either because they have to work or because cannabis is a not safe for work conversation that people can't watch at 3 in the afternoon central time. I purposely did this because it's business time for everyone. So California, it's like 1 in the afternoon. New York, it's 4 in the afternoon. So it's your standard LinkedIn business podcast time. However, given the topic, given that fact that people might have to work, I will be perhaps adding. And I think what I've decided to do is I'm going to keep doing this one because we do have people who come regularly and want to talk and interact. But I'm going to start adding on a Thursday afternoon. I think I'm going to do it Thursday. Wednesdays actually are a little bit busy in the evening. So Thursday afternoon, Thursday evening, I'm thinking around 7 o'clock, maybe 8 o'clock central. I'm leaning towards 7. That might be a little bit early for the West Coast because that'd be 5 o'clock for you guys who just be getting off work. But that might be I might be doing a 7 o'clock on Wednesday, but I don't want to be too late for the East Coast people. I just feel like 9 o'clock is just a little too close to bedtime. So maybe if I do 7 o'clock Central, that would be 8 for the Eastern and 5 for the Western Coast. Anyway, it has been great talking to you guys. Thank you all so much for joining us. You guys have a great day. And if I don't see you next week, I'll see you the week after. Take care.